This is video 3 of the muscular skeletal system. We actually ended the last video with this slide, but then I wanted to add some more to it. I want you to take a look at post-op care on page 1061 of your textbook for what you're really going to be looking for when someone is post-op. This is usually a same-day surgical procedure. It's very important that you give the patient instructions, and you're going to be looking for neurovascular compromise, numbness and tingling, coolness, lack of pulse, pale skin and nails, lack of movement, and you need to teach the patient to do the same. Just wanted to make sure that that was added before we continued with the video. Now we're going to talk about osteoporosis. As you know, your bones absorb calcium, and there's a inverse relationship between calcium and phosphorus. If for some reason the bones, don't either the patient doesn't have enough calcium, they're not absorbing calcium appropriately, maybe because they don't have enough vitamin B. There can be a lot of reasons, but the bones will become more and more fragile. Again, here's another video that I highly suggest that you watch. Bones will fracture much easier. We've talked about osteoporosis before. Large bones as well as small bones can be involved. Wrists, hip. There's a big question when an old person falls. Did their hip break and they fell, or did they fall and their hip broke? And unfortunately, we're never going to know. There's different ways that they will repair an osteoporotic bone break. They can put a special cement into the fractured bone. That's called vertebroplasty. They can also do kyphoplasty if this is all for the vertebrae. Balloons inserted through a needle into the fracture restores the fracture to where it's supposed to be, and then cement is injected. I've seen patients with that procedure many times, and it's been very, very successful. If someone has primary osteoporosis, it usually has to do with a lack of vitamin D, and you need vitamin D to absorb calcium. So this is usually white postmenopausal women, sedentary lifestyles, decreased calcium intake, lack of vitamin D, maybe they drink, smoke, caffeine. Amazingly, you'd think this would be obese people, but it's usually tiny, petite people who have fair skin who suffer from osteoporosis. There's a whole genetic thing involved, but just remember that their calcium intake is decreased, and that's a risk factor. So obviously one of the teaching points would be to have them increase their calcium intake, and then of course their vitamin D. Signs and symptoms, they usually don't, I shouldn't say that. If they have kyphosis, the hump on their back, they know they have osteoporosis if they're losing height. But they don't, quite often if people aren't getting regular checkups, they might not realize they have osteoporosis until they actually have a fracture. And that might be too late. So you really want to encourage your patients to have regular checkups. They do bone density scan for people who are at risk or have a familial history of it. It's diagnosed with all kinds of things, X-ray, ultrasound, CAT scans. It's really good. This dual energy X-ray really looks at the porousness of the bones, and it's good for them to, and they do it usually of the hip, and it's good to have a baseline, and then a bone mineral study is also very good. Treatment is meds, diet, exercise, and then safety to prevent falls is incredibly important. When we talk about medication, we want to use medications, but usually we want to make sure that they have an exercise plan in place, because if the muscular system is strong, it will take the hit for the bone. So that's very important. But along with that, we can add some meds. They can use estrogen replacement therapy, which there's controversy on that, whenever you use hormone replacement. But estrogen helps the metabolism and the absorption of calcium. We can also give calcium and vitamin D. So if they have it a higher level nutritionally, then they'll absorb more. The next line of drugs is biophosphonates, and we're going to talk about those just a little bit and in a future slide. And then very rarely, but sometimes they'll use selective estrogen receptor modulators. We're not going to get into that too much. Just know that they can use them, and there's a slide on it. Evista is the drug of choice when you're talking about SERMs. But let's go with other ones first. Calcium and vitamin D. Almost every woman who's in her late 40s or 50s should be taking a calcium and vitamin D supplement. That wards off a whole host of things, including osteoporosis. They don't have to have a below normal calcium to take it. They just need to, you can start out with calcium supplements that just come from CVS or Walmart. They don't have to be high level ones. Now, if they're deficient and they just can't keep their serum calcium up, then they have to do other things. But it's totally fine to suggest that any menopausal woman start taking calcium and vitamin D. They also want to take calcium at night because calcium is absorbed at night, at rest, when the body's at rest. The next class of drugs, and you will see these a lot, especially in long-term care situations. These are the biophosphonates, Fosamax, Actonel. I see those a lot when I was in practice in the nursing home, and sometimes even in the hospital. The biggest thing about these drugs that you need to remember is that when you take them, you need to sit up. The patient needs to sit up for 30 to 60 minutes to prevent an esophageal irritation that can turn into an ulceration. If this isn't done, the patient can suffer from like GERD symptoms, and eventually they could probably have a real issue. If they're not sitting up, if they're not taking it as prescribed, they can end up, they call it dyspepsia, when digestion just becomes painful. And that's just because the drug is causing a rawness in the esophagus and down into the gut. Their abdomen will be uncomfortable. They'll have a sense of fullness. They might have heartburn. Nausea and vomiting and loss of appetite are the more severe ones. So you want to make sure that this patient's taking the drug effectively, and of course educate them appropriately. But you will see Fosamax and Actonel quite often. And again, here are the SERM drugs. Evista is the main one. You see it occasionally, but not as often as you see Fosamax. Here are some diet recommendations, along with supplemental foods that are high in calcium can also help. On this slide, exercise, exercise, exercise. Because, again, like I said before, if the muscles are strong, they will take the hit for the bones that aren't as strong. Next, we're going to talk about Paget's disease. This is not a very common disease at all. It's a bone disease in which increased bone loss results in large disorganized bone deposits throughout the body. It's pretty horrific in what it does to the person and what they look like. Here is some pictures of patients with Paget's disease. So you can imagine the psychosocial issues that are going along with this. Paget's disease is most always seen in the skull, the femur, the vertebrae, and the pelvis, those big flat bones. They don't even know what causes it. They don't have a genetic link for it. Usually it affects men, and usually in their middle age. It's diagnosed with X-ray, and obviously you can, start to see changes in the patient's shape. And then the only lab value they see is alkaline phosphatase is increased in this syndrome. Signs and symptoms start with bone or joint pain. The long bones start to bow. Um, they lose the normal spine curvature, so it becomes abnormal. Their skull thickens. They have pathological fractures. Um, they can also have headaches if the skull enlarges, and in severe cases, they can have um, blindness or deafness if it's putting pressure on the nerves. They treat it with calcitonin or a thyroid hormone to decrease the bone loss. They use Didronel, which is a calcium regulator. And just like Fosamax, give it on an empty stomach. Don't give it within 2 hours of vitamins, antacids, or meds high in calcium, mag, or aluminum, because then, of course, it won't be absorbed properly. Mithracin is a potent anti-cancer drug, and it suppresses the osteoclast and osteoblast activity, which when somebody with normal bone structure takes this kind of drug, the suppression of osteoclast and osteoblast is a bad thing. But in this case, it can be helpful, but it's very, very important that the liver and kidney function is monitored. And this patient, like a patient with osteoporosis, may be prescribed Fosamax. So we're going to talk about cancers in general in the next section of videos, but just so that you have an idea, a patient can have bone cancer that is its own pathology. Quite often, like a stage 4 cancer means the cancer has moved to the bone. And when that happens, it's very hard to cure. But sometimes people will start with a bone cancer, osteosarcoma. And unfortunately, it usually metastasizes somewhere like the lungs, and it is tragic and not at all pleasant and hard to cure. It can be diagnosed, bone cancer can be diagnosed with bone biopsies, x-rays, CAT scans, MRIs. Whenever someone has a biopsy of any kind, and again, we'll talk about this more in the cancer unit, but the only way to truly diagnose a malignancy is by bone biopsy. Yes, you can do MRIs. Yes, you can do all of this stuff, and they'll say, yes, it looks malignant. Yes, I think it's malignant. Yes, it resembles malignancy, all of that kind of thing. But until they actually get a piece of that tissue, it's not confirmed that it's malignant. When someone has a biopsy, wherever the site is, obviously it's the nurse's job to control pain, prevent bleeding, all of those basic post-op situations. And again, we're going to talk about cancer more in the next unit. So let's talk about connective tissue disorders. And I'm only going to really talk about, I'm going to talk about systemic lupus erythematosus, scleroderma, fibromyalgia, chronic fatigue syndrome. I'm going to let you learn those on your own because the slides are very inclusive and you'll be able to read and use the slides in your textbook to get that information appropriately. But I will talk about systemic lupus erythemus a little bit because I think I have some things I can add to it. The pathology, it's an autoimmune disease. They have no idea what causes it, and there are remissions and exacerbations. It travels in families, but they haven't linked it to a specific gene. Women have it more than men, and blacks have it more than whites. It's triggered by genetic, hormonal, and environmental factors, but like I said, they have not secured a gene. And so you can have effects from it in any connective tissue system in your body. And there are a lot of them. We'll continue in the next video.